Okay. Could you start?
Yes, sir. I've started recording also.
Okay, fine. So, um, good evening, everyone. Welcome all to the BOA PG lecture session. As you know, the thing that we started in lockdown, we have continued till December whole of this year, and we take a specialty lecture every month. Today, we have a day for a pediatric ophthalmology. As you know, we have covered the basics of all the examination and the medical management, but the surgical management is very important part of the Squint. And to cover that, we have Dr. Sumitha Muthu with us. She is a consultant at Narayan Nethralaya, Bangalore. She has done her PG from Minto Hospital, Bangalore, and followed by her pediatric ophthalmology fellowship from Narayan Nethralaya. And now she's practicing at Bangalore itself. Welcome, Sumita, and thank you for accepting our invitation. Over to you.
Thank you very much, Dr. Sumit, and also the Bombay Ophthalmic Association for giving me this opportunity. It's always a pleasure to be with students and teaching them. In fact, I learn a lot when I teach them too. With no delay, I'm going to start with squint. How squint surgery can be very simple. So a lot of people think that, okay, squint surgery is a very simple thing. All you have to do is loosen a muscle to actually weaken it or tighten a muscle to strengthen it. So the question is it that simple or is it more complicated than that? So and that's all, folks. But that's not the case. It's not that simple. Okay, for example, let me take an example of a third nerve palsy. Just imagine a patient presents to you with a third nerve palsy with the eye turned out and down. Now, what are the options available in such a patient? Okay, so one, you can do a medial rectus resection and LR recession and a lateral rectus recession to correct the exotropia. Or you can do a transposition of vertical recti, that is transpose the superior and the inferior rectus to the medial rectus. And third, you can do a bilateral lateral rectus recession and a unilateral MR resection, or a split transposition of the lateral rectus muscle to the MR. So now to answer that question, is it actually very simple? So if you see, the options available here are several. So if you have the knowledge of all these procedures that are available, and if you clinically evaluate the patient properly to choose what procedure you need to do in such a patient, then of course it is simple. So I'm very glad that the evaluation part has already been covered, and also the non-surgical treatment has already been covered. I hope you're all thorough with that. But at any point, if you feel the anatomy or anything as such has to be touched again, please feel free to add that in the chat box, and I can touch upon it whenever you get confused. So whenever you're offered with options like that, we are often left confused as to what option to choose. So like I said, when you have a question in mind as to what surgery to do in that patient, you equip yourself with the knowledge as to what all options are available and what best suits that particular profile of the patient. Then of course you can make the decision. So once you know how, once you possess the knowledge, then you know how or know what procedure to do in that particular patient. So the content of my presentation is going to be the follows. First, we shall cover the basics of recession and resection, which is about, I would say about 80 to 90% of the common squint surgeries that are done, and certain adjuncts to recession and resection, surgery on oblique muscles, transposition surgeries, special and some interesting surgical procedures, and how to train yourself to perform squint surgery. Certain tips I shall just be giving them in the end. So coming to basics of recession and resection. So see, like I told you in the beginning, that to weaken a muscle, you just loosen it. Is that all that is? So when you actually recess a muscle, for example, when you're taking the muscle back here, so of course the muscle is slackened, but what happens? You know that the muscle is made up of several sarcomeres, right? So what happens is defined by this curve. So if you can see this curve, this is the force that the muscle generates, and this is the length of the muzzle. Okay, so this is the force and this is the length of the muzzle. If you look at contractility, okay, so as the length of the muzzle increases, the contractile force of the muzzle goes on decreasing. Okay, so if you see, the contractility is at a peak over here when the muzzle is of its normal length. Okay, also when you shorten the muzzle, that is during a resection, note that there is some amount of decrease in contractility. Now how do you explain that? So that is explained by the loss of sarcomeres. You're actually losing the muzzle tissue as such. So therefore the contractility also reduces when you resect the muzzle. Again, how the recession works is with respect to elasticity. As you lengthen the muzzle, the elasticity of the muzzle increases, and as you shorten the muzzle, the elasticity decreases. So it's also like almost like a the eyeball is being held mechanically by a resected muzzle. That's how the elasticity decreases as the muzzle is shortened. Okay. So coming to certain basics of recession and resection, there are several variables, meaning some do limbal-based surgery, some do fornix-based surgery. I'll also come to other variables which can be seen in recession and resection. So what are the advantages of limbal-based surgery? You can do it very fast, okay, and it's relatively easier because once you cut the limbus, so for example, if this is the eye and you have incision which is taken here, then that is a limbal based surgery. Okay, usually you take a curved incision like this, okay, either close to the limbus or this is almost like a paralimbal incision, and give relaxing cuts on two sides and expose this conjunctival flap. And once you expose, for example, take this is the medial rectus and it is at about 5.5 mm from the limbus, and you can see the insertion of the muzzle almost immediately. Okay, and it's not very difficult to recognize it because there are there's no too much tenons anterior to it, so it's easily exposed. Okay, so you get a wider exposure once you give this relaxing cuts. You get a very wide exposure of the entire area around the muzzle. And limbal incision is definitely preferred in re-surgeries because of this reason, because it gives you a wide exposure and it's easy to expose the muzzle. Therefore you prefer limbal based incisions in case of re-surgeries. So coming to fornix based incision. So what is a fornix based incision is, say this is the eye and your fornices are here. So what you do is, if this is the muzzle, you take an incision somewhere in the fornix. So usually the incision is taken in the infratemporal fornix so that the sutures get hidden behind the lower lid. Okay, so once you take the incision here, you know that the muzzle insertion is quite far from it and you actually have to hook it and separate it from all the attachments of the muzzle. So if you look at the attachments of the muzzle, one second. So if you take this to be the muzzle, what do you have anteriorly? Anteriorly to the conjunctiva, almost coming perpendicular like this from the surface of the muzzle, is the check ligaments. So they can be more than one. Of course, there's one close to the insertion, and posteriorly there can be more check ligaments which attach the muzzle to the conjunctiva and the Tenon's capsule over it. Okay, and then between the muzzles you have the intermuscular septa. So these are the intermuscular septa. Okay, so when you pass the hook of the muzzle, it should be in this area. So that is why we always say that there should be a bare sclera area when you start hooking the muzzle. So I think more intricate details, when I show you the video, I'll show you how it is done. It can get a little confusing over here. Okay. So what are the disadvantages of a fornix based incision? That it takes a longer time, because I told you, in what way you need to hook the muzzle. So definitely it takes a longer time. And it is more difficult because you need to identify the structures over there. So in case you see the intermuscular septum in that area, you need to identify that's the septum. And if you see the muscular tissue, you need to identify that this is actually the muscular tissue. Of course, how they look, they're all different. That comes with experience. And also as you start, doing the enucleation procedures, you can make out the difference between the muscles. I'm talking about the enucleation in diseased. And the exposure again is limited over here because the incision that you're taking is so small that the exposure is limited. So eventually, as you keep passing instruments through the incision gets stretched like this, but initially it is small. So yeah, that's why the exposure can be limited unless you don't stretch it. Then of course, the main reason why most people go for fornix based incision is for this. It is for better cosmesis. So the scar is of course hidden. So even if it does not heal well, the scar is almost hidden under the lid. So therefore, it gives a better post-operative picture. So yeah, before we go to the other variables that can be seen in a resection, I'm going to show you a short video on each step of recession and resection. I don't know. Yeah, so if any of you, how many of you have actually seen squint surgeries? Could you just say yes, 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 or something like that on the chat box so that I know how many of you have seen and how detailed I need to explain? Yeah. Dr. Durga, can you please take care of the chat box for me and just update me on?
Yes, ma'am.
Yeah. Can you just tell me how many of them have actually?
Ma'am, 2 to 3 people are saying they have seen the squint surgeries.
Okay.
Others, two are saying no.
No. Okay. Great.
You can take it as
So,
50-50 something.
sorry.
50
You
50,
can
ma'am.
take it as 50.
Okay. Sure. Sure. Done. Done. So we shall take it a little slowly then.
Okay, ma'am.
Some trouble playing the video. Yeah. So first step that is, sorry. I'm sorry. 1 second. Yeah. So first step that you do in a fornix based surgery. So I generally practice fornix based for most of my recession and resections, and only for the resurgeries I take a limbal based surgery. So first step that you do is, so now I'm trying to operate the lateral rectus. Okay, so you can see here that my this is a fixation forceps. So what you do is you fixate it on the infratemporal limbus. Okay, and you take the eye in the opposite direction. So you need exposure of the infratemporal area. So once the infratemporal area is exposed, oh, I'm sorry, I'm so sorry. I think. Yeah. So next is to take an incision in the infratemporal fornix over there. So all you have to do is do a nick with a scissors, conjunctival scissors. Okay. And next you take a hook, a blunt hook. So I'll play it again for you. So that's a blunt hook. It's called a Von Greffes hook. I think I will just play it this way so that I can pause it at any point. It's just going into presentation mode, so it's a little difficult. Yeah. So we just play it like this. So that's a fornix incision. Then that's a Von Greffes hook, a blunt hook. So here you have to make sure that you're actually posterior to the muzzle insertion. Okay. So if you're not, when you're sweeping across the eye, if you're not posterior to the muzzle insertion, then what happens is that you will come anterior to the, you'll come anterior to the insertion. Oh, 1 second. Yeah, you'll be anterior to the incision and not hooking any muzzle at all. I think let's watch the video and probably later I'll explain. So this is a Jameson's hook, which is again being passed to secure the muzzle. This is a small hook or the Stevens hook to separate the conjunctiva, which is overlying it. So the Jameson's hook, and now you can see the Stevens hook, which is retracting the conjunctiva, which is present over it. And next you separate all the attachments of the muzzle. So this is a check ligament from the muzzle to the conjunctiva, the one that we knit. And on the sides where the intermuscular septa. So next you pass the second hook over here. Shit. Oh, I think it is because of my pen. Yeah. And next you secure the muzzle at the insertion. Okay. So you can secure the muzzle either using a double arm suture, that is needles on both sides. Okay. Here I'm using a double arm suture. So you pass a suture like that, and then most kind of sutures involve a partial thickness on either sides and a full thickness suture. So here I want to ask a question to all the students there as to what is the type of suture which actually secures the muzzle. Is it the partial thickness suture or is it the full thickness suture? What should you be careful about? Can you please reply in the chat box? So you have a muzzle there. Okay, let me just show on an empty slide. Yeah. So say you have, this is the cross section of the muzzle that I'm showing. Okay. So initially what incision you take using a double arm suture is kind of like this. You go this way. Okay. And then you take a partial thickness suture and a full thickness suture. Okay. Again, take a partial thickness suture, lock it. All the times when you take the sutures, you always lock it. Okay. So please tell me, what is the suture that actually holds the muzzle? Is it the partial thickness suture or is it the full thickness suture? Do we have answers? Dr. Durga?
Not yet any answers, ma'am.
Would you like to take the question?
Partial thickness suture.
Okay, very good. So it is the partial thickness suture which actually holds the muzzle. So yeah, the same diagram that I showed, just imagine. I would want all those who are probably having a snack in the evening because of a video class or freshening up to actually stay hooked to the class. Okay. I'm known for taking names during class, and I don't think a video class will stop me from doing that. Okay, so this is the muzzle. Okay, if you see, the partial thickness is the one which actually holds the muzzle, because these fibers cannot easily slip. You're actually holding a part of the muzzle. Whereas a full thickness, the entire muzzle can just slip through it very easily. And that's why it's the partial thickness suture which actually holds the muzzle. Okay. So let's continue with the video. So once you secure the muzzle like that with the sutures, next you disinsert the muzzle from the insertion. So you should make sure that your sutures are not very close to the insertion. Okay. Only then will you have sufficient space to actually cut and disinsert the muzzle. Okay. Yeah, so we covered that. Sorry. So this is the disinsertion of the muzzle. And once you disinsert, place the fixation forceps again on either sides of the insertion, and then mark 3 points, one at the center and 2 on either sides. So now you fixate the muzzle to this new point on the sclera. So we use a straight calipers. Some people prefer to use a curved ruler kind of thing on the globe. Yeah, but what happens is once you disinsert a muzzle, the globe is no longer that very curved. It's actually slightly flattened. So even a normal caliper would actually do. So this is the interrupted conjunctival sutures. So for a limbal incision, it's better to use buried knots. Whereas for the fornix incision, you can just use normal interrupted sutures. So how the suture differs for a resection is, See, once you expose the muzzle, the same steps, whatever I described before. So once you expose the muzzle, what you do is you separate all the attachments and mark the amount of resection that you want to do on the muzzle itself using a caliper. Say you want to do 5 mm of resection, mark that 5 mm point. So at this 5 mm point, start passing the double arm suture. The double arm suture slightly differs from for a resection from the one that's used for recession. So in a resection, what you do is you secure the central fibers like this, okay, and then sorry, yeah. So bury this knot by actually taking this suture underneath. So what happens is once you pull this knot goes underneath, okay. So now the knot is underneath over here. And next, same thing, partial, full. Then again, partial, full. So at any point you feel your partial thickness suture is not satisfactory, you have taken very superficial fibers, always feel free to take more partial thickness sutures. Okay. So we were doing resection. So once you secure the muzzle like that, yeah. Next, this step is very important. You need to clamp the muzzle because in recession, the place where you're cutting the muzzle is actually at the tendon where blood vessels are few. It is not very vascular. It's not the muzzle bulk that you're cutting. Okay. So then it doesn't bleed too much. Whereas for resection, you're actually cutting through the bulk of the muzzle where it's very vascular. So it's very important to clamp the muzzle. Okay. So you clamp the muzzle using a mosquito forceps or an artery. Then you cauterize all the major blood vessels that you're actually seeing. In fact, try to cauterize the entire muzzle and blanch it out like that, like you can see there, and then cut. Okay, so resect the remaining stump. Again, apply fixation forceps on either sides. So now you measure the width of the muzzle, then mark that point at the insertion. Oh, I think it's my pen that's stopping the video. Sorry about that. Yeah. Yeah, measure the width of the muzzle and then mark. Okay. So once you mark, yeah, so this is the way I take a resection suture. But a lot of people, what they do is they go from behind the stump and go underneath the stump and anterior to it. Okay. So I hope you understood what that means. I'm sorry, because it's very difficult for you to imagine, I'm having to resort to drawing a diagram every time. So say this is the muzzle stump once you have disinserted it. So you have the suture there. So what most of them do is, if this is posterior and this is the cornea there, okay, what most of them do is they start here behind the insertion, go underneath the stump and then come anterior to it. Okay, so this is all underneath. This is all underneath. And then finally you come out. So I hope you got that picture. So this is how they take for resections. So by anatomy, can you all tell me which is the thinnest portion of the sclera? The chat box, please. Chat box. Thinnest portion of the sclera. Or you can, anybody can just unmute and answer. Please feel free to interact. You're not going to be penalized for not knowing squint surgery. You're not expected to know because even when we were in post graduation, most of us haven't seen a squint surgery. Okay. Near the equator. Okay, thanks for trying, Dr. Meghna, but no, not near the equator. Can somebody else try, please?
Ma'am, insertion of the extraocular muscles.
No, yeah, no, not Dr. Durga. I want answer from somebody else.
Okay, ma'am. Sorry.
Yeah, thanks, Dr. Durga. If nobody answers, I will come back to you.
Okay, ma'am.
Yeah, come on. It's okay. A lot of us neglect anatomy. It's okay. You can try. So there are only some 5 different places on the sclera. So guess all of them. What is there? Okay, I'll give you 4 choices. Um, is it close to the cornea? Is it close to the insertion? Or is it 13 posterior to the limbus? That's a good guess. I guess that would be roughly the mark for equator. Dr. Disha is saying 13 posterior. So that will roughly be the area where the equator would be. Okay. So let me give you the, I think Dr. Durga would like to answer. Yes. Thank you all for participating actively. It really keeps the class going. I mean, I really miss taking a conventional, normal class with you students seated in front where we have free hands to interact. So this is actually encouraging a similar class. Yeah, Dr. Durga, please go ahead.
Ma'am, it is usually just behind the insertion of the extraocular muscles.
Yes, that's very good. So the just behind the insertion of the extraocular muzzle, the sclera is as thin as almost zero point 0.3 millimeter or 0.4 millimeter. Okay, so that's very thin. What is normal thickness? Normal thickness is about 1 millimeter. Close to the cornea and all is about 1 millimeter. Okay, so you can imagine how thin that is. So if okay. So if this is normal thickness of the sclera, which is equal to 1 millimeter, zero point 0.3 is only 1/3 the thickness. Okay. So passing a needle through 1 millimeter is quite easy, right? Chance of perforation is very less. So imagine it's just 1/3 thickness and you have to pass a needle through that. So definitely the chances of perforation in such a case can be very high. Okay, that's the reason why out of experience, I prefer to use I come anterior to the insertion where the sclera is actually 1 millimeter thick and I take the incision here. Of course, there is a minimal effect of, you're actually anteriorly fixating the muzzle than the original insertion by almost 0.5 or less than 0.5 millimeter. So I adjust the parameters, the resection parameters according to that. Okay, it usually doesn't matter. I hope you all got it. Okay, why this kind of anterior incision probably at least for beginners is way better because of this reason. So this is only 30% of the scleral thickness and this is 100% of scleral thickness, right? So that is preferable. Okay. So yes, and again, once you take that incision, one of the important steps in resection is, I'll just come to that. So resected muzzle is a tight muzzle, agreed? So it is difficult to pull it to the insertion because you have shortened the muzzle, right? So yeah, so once you pull, what happens is, so once you pull and bring it to that particular point, it can go back. In case you don't hold the knot, it can go back. So then you don't get the expected effect of the resection. So that's why you use a single knot. Whereas in resection, you straight away start with 3 knots. Okay. Whereas in resection, you start with a single knot, ask somebody to use a straight forceps like this and hold that knot. That step is called stepping on the knot. It's like you're putting a foot on that knot and making sure it does not, recede back. So yeah, then you step the knot and complete the rest of the sutures. So this is conjunctival suturing, again interrupted sutures. So you hold the incision on either sides like this with the help of fixation forceps that you use to hold the limbus and then suture it like this. Okay. So that's a resection. I think I'm taking more time than expected. Okay. So how much to recess and resect? Yeah. Did I cover other variables in surgery? I guess not. Okay. I guess that slide is missing. Yeah. So what I want to tell you is what are the other variables in surgery that can happen? What else can you do? One is, of course, you can either choose a limbal based or a fornix based incision. The second thing is the measurement. Okay. The measurement can either be from the limbus. So if you take, so you can always choose to start measuring from the limbus, okay, as to how much you have to recess, mark the point on sclera, or you can choose to take the measurement from the insertion point. Okay. So what is the difference? Why there has to be two different ways of doing it? What people believe is that once you disinsert a muscle, that the insertion probably migrates a little bit anteriorly. Okay. This is because the scleral fibers are actually trying to pull the insertion anteriorly. So that's why some people prefer to take the measurement from limbus and not from the insertion itself. So this is one of the differences in practice that you notice among surgeons. And the other is, of course, the limbal versus the fornix based incision. And some people follow something called hangback technique. Okay. So when you recess a muscle, what we practice is insert the muscle where you want it to be, right? So this is where the muscle is going to be. But in case you don't, the insertion is very posterior and you don't want to go so deep down where it's difficult to actually pass a suture on the sclera, then what you can do is take the bites anteriorly, let the suture hang back. Okay. So let the suture hang back like this and the muzzle hang at the region where you want it to be. So this is a hang back incision. Okay. So that's another variation in the type of surgery that people practice. Okay. So coming to how much to recess and resect, I follow the Rosenbaum's table, wherein if you see the last few pages on Rosenbaum's book for squint surgery, there you will find a table which gives values for recession and resection. Okay, how much you should recess for this much amount of deviation. So I follow that. Some people follow an algorithm like 1 mm recession equals X or resection equals Y. Okay, so for LR and MR it's different. For LR you need to resect more amount of muscle to correct the same amount of deviation. Whereas for MR, which is actually a shorter muscle, you need to do less amount of resection to achieve correction of the same amount of deviation. Okay. So what each person follows is very different. So what should you follow? What are the advantages of following an algorithm like this, or disadvantages of following an algorithm like this is, once you recess too much, say after you recess about 7 or 8 millimeter, say up to a particular amount, so up to 6 millimeter or 7 millimeter, you may equate 1 mm of recession corrects this much amount of exotropia. Okay, but beyond 7 or 8 mm of recession, the same amount of recession, like 1 mm, does not correct that much amount of exotropia. It corrects less. What is the reason? Because if you look at the globe, so this is the globe, and once you start recessing too much, you're coming close to the equator or even beyond the equator. At this point, the effect of inserting a muscle posterior to the equator is not the same as inserting anterior to the equator. And that's the reason why when you do large recessions, you don't get the same effect. Okay. So it's better to follow tables, or best is you develop your own algorithm. So once you do several surgeries, then you know that in your hands, each mm of recession gives this much effect and each mm of resection gives this much effect. So when do standard calculations not work? So standard calculations don't work when the recessions are large. I just told you why it does not work. And when the resections are large. So why, when the resections are large, that standard calculation does not work? For this, you have to go back to the table that I showed you before, this curve that I showed you before. So once you start resecting too much, then what happens is the contractile force of the muscle starts reducing. And that is the reason why standard calculations don't work when you do large dissections. Okay. Then in peretic squints, obviously, because is that a normal muscle? It's not a normal muscle to give you the expected effect. It's an abnormal muscle, and therefore it does not give you the expected effect. And restrictive squints. So if you recess a normal lateral rectus, then say it corrects about, say if you recess about 5 it corrects maybe about 15 PD of exotropia. In restrictive squints, say the lateral rectus is actually pulling the eye out tightly. When you recess that tight lateral rectus, the amount of squint correction that you get is much larger. Okay, because it is mechanically holding the eye in that direction. So once you recess the muscle, the correction of the squint achieved is much larger. Okay, and of course in mixed etiologies. So when you have both peretic and restrictive components, which can happen in, can you give me two etiologies where both paralytic and restrictive component can be there? Okay, at least one etiology, guys. Chat box. One etiology, come on. Okay, so I'm gonna try and pick some names. I think, okay, so we will just Dr. Meghna or Dr. Disha, who answered before, would you like to take the question? So what is one place where you may find both paralytic and restrictive squints? Okay. So you guys are able to hear me? Dr. Durga, you're there?
Yes, ma'am. We can
Yeah.
hear.
Can you give me one etiology?
Ma'am, Dr. Meghna is saying third nerve palsy.
Okay. Yeah, good. So see, in a palsy, of course, good. Thanks for trying. And definitely, there can be a paralytic as well as restrictive component. So why paralytic? But the paralytic component is major. Okay. Restrictive component comes later, much later in a long-standing third nerve palsy. Once the lateral rectus becomes very tight because of contracture, then maybe a minor restrictive component may come in. So where do you find both damage to nerve as well as scar? So that is your clue. Dr. Meghna, you can only try. So you also have damage to the nerve and you also have scar tissue developing inside the orbit. Where can that happen? In? Very good. Yeah. So it is in trauma. Okay. So you can have both, a restrictive component because of, thank you, Dr. Aarti, for answering, because of the mechanical component, that is because of the scar tissue holding back the muscle, or because of direct injury to the muscle and part of the muscle being replaced by scar tissue, or and a paralytic component because there is also some damage to the nerves. Okay. So that's how both components can be there here. So when else do these normal calculations not work? Okay. I would say, why are my slides not moving? Can you see my presentation, Dr. Meghna?
Ma'am, we cannot. We can just see one slide of yours. The next we cannot see.
Wrong. Probably not. Yeah. So I would say pretty much all surgeries. Okay. So when is the standard calculations not work? The reason why I said all surgeries is, see, say two patients present to you with a deviation of 50 PD. Okay, 50 diopter of 50 prism diopter of exotropia. Two patients present to you, and you do the same kind of surgery in both these patients. Do you think the post-op results in both these patients will exactly be the same? No, that almost never happens. Okay, what is the reason why that doesn't happen? The reason is that the sensory adaptation that occur post-surgery plays a major role in the final deviation that is achieved. Of course, on the first post-op day, what you see depends very much on your surgical technique, as to how much the numbers that you calculate, the amount of recession and resection, it all depends on that. Whereas the eventual outcome, that is, once you see the patient after 2 months, the same amount of surgery for the same amount of exotropia will not give you the same amount of same kind of result. Okay, the reason is because of the sensory adaptations that occur. Next, coming to the adjuncts to recession and resection that we use. So one is the posterior fixation suture, and the other is the adjustable and the semi-adjustable procedures. So I shall briefly describe both. So in the posterior fixation suture, which is used for recessions, what it does is it enhances the effect of the recession in the direction of action of muscle. For example, in high AC by A ratio esotropia, what you do is once you recess both the medial rectors, for esotropia, you recess the medial rectors, right? So once you recess both the medial rectors, you also place a suture on the muscle to the sclera. Okay. I think it's a little too much for the class. Okay, I'll try and simplify this for you. Yes. Okay. So what is a posterior fixation suture? So say this is the eye. Okay. And this was the original insertion of the medial rectus. So you disinserted the medial rectus and actually placed it here. All right. So this is the medial rectus. So posterior fixation suture is when you pass a suture from the muscle to the sclera about say 8 mm or 14 mm. So it can be anywhere between 8 to 14 mm. All right, 8 to 14 mm behind the muscle and to the sclera. So what does this achieve? Say this is the right eye and you're looking at it from above. And this patient has esotropia with high AC by A ratio. I think squint evaluation has already been covered. So I hope you all know what AC by A ratio means. So I shall just simplify that for you. Okay, what is AC by A ratio? So you know the numerator is accommodative convergence. Okay, it's accommodative convergence. The denominator is accommodation. So kindly excuse for my handwriting. So it is the amount of convergence that occurs for every diopter of accommodation. Say for example, there is an object or a target which is about 33 centimeters in front of you. Okay. So if an object is there 33 centimeters in front of you, what is the amount of accommodation that you need to exert? Quickly chat box, please. Sorry. I'm very much not used to a non-interactive class. Come on, people. For 33 centimeters, what is the amount of accommodation you need? Who's good at optics? Okay. So I will give you options. Is it 33 divided by 10? Or is it 10 divided by 33? Or is it 100 divided by 33? Three options. Would you like to choose? So the three options are 33 divided by 10, 100 divided by 33, and 10 divided by 3. A, B, C. Come on, quickly. All you have to do is put one letter on your chat box. Let me see how many of you guess correctly. So what is the amount of accommodation you need for a target which is 33 centimeter in front of you? Okay. Great. So we have one person responding, 100 by 33. So do we finalize that as the answer? Okay, great. Yeah, thank you, Dr. Aarti again. So that's the correct answer. 100 divided by 33, which is equal to 3 diopter. So for a target which is about 33 centimeters in front, the amount of accommodation that is required is 3 diopter. Okay, 3 diopter. So what is normal AC by A ratio? One second. Normal AC by A ratio is, okay, since I'm 3 to 5 prism diopters. So if for 3 diopter of accommodation, then how much convergence should be happening? If the patient has normal AC by A ratio, the amount of convergence that should be happening for 3 diopters, say we take the average to be 4, is 12 prism diopter of convergence, right? But if we have a patient with high AC by A ratio, say the AC by A ratio is actually 7 in that particular patient. Okay, so then that gives you 7 into 3, which is equal to 21. So for the same target which is present here, the person is accommodating about 21 prism diopter. So this particular patient with esotropia with high AC by A ratio, once you do medial rectus recession conventionally, will be completely corrected for distance. He'll be orthotropic for distance. But for near, he will still have about 21 prism diopter of esotropia. So such patients can be addressed by actually putting that posterior fixation suture. Okay. Because what the posterior fixation suture does is it limits the action of the muscle, which is it limits the adduction action of the medial rectus in the direction of the action of the muscle. So more the patient converges or adducts, more is the limitation of the action of the muscle. And that's why posterior fixation suture is used in that situation. Okay. I hope that was clear. Then adjustable suture, there are 2 commonly used techniques, which are the sliding noose technique, which is this is the sliding noose technique, and this is the bow tie technique. In bow tie technique, what you have to do is, so many a times what happens is once you tie a shoelace knot, the second time, maybe you don't make loops from both the ends and make loop only from one end. Then what happens is the one end which you have not used for making a loop can actually be used to untie the whole knot, right? I think a lot of you would have accidentally come across that when you're tying a shoelace. So that's nothing but the bow tie technique. Okay. This is the semi-adjustable. So adjustable you saw is when the entire muscle is either pushed back or pushed in front. Okay. So you keep the suture here adjustable such that you can either push back the entire muscle later on the first post-operative day, or you can push the pull the muscle forward. Okay, that's adjustable. In semi-adjustable, what you do is only the central 1/3 or half of the fibers are actually secured with a separate knot, and this central fiber can either be pulled forward close to the insertion or can be pushed back like this. Okay, so this is a semi-adjustable procedure. I don't have any experience with this, so I don't know the results, how good they are. So coming to surgery on oblique muscles. So before you start operating or even seeing oblique muscle surgery, you have to learn the anatomy of the obliques very well. So you should definitely know that it takes origin anteriorly and inserts posterior to the equator, and therefore the action of the muscle is opposite. So what happens is, so this is the inferior oblique, which takes origin from the floor of the orbit and then inserts to the postero-inferior lateral quadrant. So this is the lateral part. So you've taken off the lateral orbital wall, and this is the view that you get, which is the lateral rectus muscle, here the superior oblique tendon and the inferior oblique. Okay. So what happens is when the muscle contracts, what happens? It's actually bringing this part of the globe down. So what happens? This is like a sphere, right? So when a sphere is rotated, I'll just show you. So what happens when a sphere is rotated? Okay. So if you look at this, say this is the superior rectus, their actions are very simple. So once the superior rectus contracts, the eye elevates. And if the inferior rectus contracts, if this particular muscle contracts, then the eye depresses. Okay. Because their insertion is anterior to the equator. The blue line that you're seeing is actually the equator. Okay. So what happens to the oblique muscles? The oblique muscles are inserted posterior to the equator. So it is behind this. So what happens when inferior oblique contracts? The posterior part. 1 second. So I'll just show you. So this view is better. So what happens when inferior oblique contracts is it is depressing the posterior part of the muscle. 1 second. So it's depressing the posterior part of the muscle. Can you see what is happening to the anterior part of the eye? It is elevating. So say for superior oblique tendon, same thing. It is inserting superiorly, but it is posterior to the equator. So what is it doing? Superior oblique tendon, when it contracts, it is elevating the posterior part of the muscle. But what happens in turn? The anterior part depresses. So that's how inferior oblique elevates the eye and superior oblique depresses the eye. I hope that is very clear. Okay. So when inferior oblique contracts, it elevates the eye, and when superior oblique contracts, it depresses the eye. Dr. Durga, how much time do we have?
Ma'am, it is 8 o'clock. I guess another 10-15 minutes. You can...
Are you sure?
Yes, ma'am.
Okay, I'll try and wrap up as soon as possible.
Okay, ma'am.
The inferior oblique tendon, the anatomy, and this is superior oblique tendon. So the functional, though the superior oblique tendon actually originates from the apex of the orbit, the functional origin is this. So that is why I say the muscle originates anteriorly and inserts posterior to the equator. This is the equator. So it's inserting posterior to the equator. Okay. So when to perform surgery on obliques? When you find pattern strabismus with overaction of obliques, like for example, A pattern or V pattern. So you all know this mnemonic SINRAD, that superiors intort and recti adduct. So obliques actually abduct. The reason why I quoted this is to remember that obliques abduct the eye. So if you find A pattern strabismus, can you tell me which oblique is overacting? Come on, quick. I think I already told the answer. Do you have any answers? No? Okay, so A pattern strabismus is because of SO overaction. Okay. So as you know, SO superior oblique depresses the eye. So in down position, in the depressed position, if the eyes are going apart, it's because of SO overaction. Okay, because the obliques abduct the eye in that position, and therefore there's an A pattern. V pattern strabismus is of course associated with inferior oblique overaction and needs IO weakening. And when else to perform surgery on obliques? When you find SO palsy, DVD. Rarely you also do a SO transposition for complete third nerve palsy, because the only functioning muscle in a complete third nerve palsy is only functioning muscles rather are superior oblique and lateral rectus. So therefore you can use either of the muscles to achieve good alignment in the primary position. So when you do transposition procedures, they are done when there's a congenitally weak muscle. I think we'll skip all this. I'll just show you some animations for. So this is a patient with incomplete third nerve palsy. The child has exotropia and hypotropia. Adduction was about -5. Elevation and depression was about -2. So in this patient, what I did was, so we used the vertical muscles. Okay. So I did an asymmetric transposition here. So once we did that, you achieve good alignment in the primary position. This is transposition of vertical and the inferior rectus. So because there was hypertropia, we chose to transpose more of the inferior rectus and a little less of the superior rectus. Okay. Okay, that's done. And this is a patient with inferior third nerve palsy. So what does the inferior division supply? Superior rectus, superior rectus and levator palpebrae superioris is supplied by the superior division, and inferior rectus, inferior oblique, and medial rectus, all these muscles are supplied by the inferior division. Okay, that's why, because all the depressors are gone, the eye has gone up. All right. So this patient, so you can see that the elevation is good, but depression is not good. The eye is not going down. Okay, and it's also not coming inside. All right. So both adduction and depression is limited in this particular patient. So what did we choose to do for this patient? So this is a normal alignment of the eye. Her eye was turned up and out. So we chose to transpose the existing functioning muscle, which is the superior rectus and the lateral rectus, to the infromedial quadrant. Okay. And this, as a result of this procedure, she achieved a good alignment. So even these kind of transpositions can be done. So another interesting surgical procedure is the Yokoyama's procedure. So this is done for myopic strabismus fixus. So what happens in myopic strabismus fixus is the superior rectus and the lateral rectus, they displace from the bellies, muscle bellies displace from the normal position. They start sagging like this. Okay. So it can happen in two conditions. One is the sagging eye syndrome, which can happen in elderly just because of degeneration of septa and all that, or it can happen in high myopes, wherein the globe is too large and the muscles actually slip from the original position. So in such a condition, what you do is you bring back the muscles to the postero superior quadrant, and then you suture them to the sclera with a non-absorbable suture. And then the eye gets aligned. Okay, that's a Yokoyama's procedure. And then you have a modification of that, which is the silicon band loop myopexy. So here you pass a silicon band through the sclera, take both the muscles inside the band, and then loop it over. Okay, and this achieves good alignment in the primary position. So this is a silicon band loop myopexy procedure. Okay, so to conclude, I would like to quote this by Johan Cruyff. He's called, it's pronounced as Cruyff. He's a Netherlands football player. Not that I'm a fan of football, just I'm a fan of this quote, that's all. So soccer is simple, but it is difficult to play simple. So similarly, I would like to just modify this quote that squint surgery is of course simple, but it is difficult to do the simple. All right. So I hope at least it is partially simplified for you, for those who listened. And thank you all for patient hearing and also for all the active participation.
Thank you so much for the
Thank you so
lecture, ma'am.
much.
Thank you.
No doubts, right?
No questions in the chat box,
Should
ma'am.
we give them a minute to?
Yes, ma'am. Yes, ma'am. We can wait for a minute, ma'am.
Only 60 seconds, that's all. I'm sure if they're active, then we'll come up with the question fast. So we have first year, second year, as well as third year residents, or only third year residents?
Ma'am, second year and third year.
Oh, only second year and third year. Excellent.
I think, yes.
So no first year residents.
Ma'am, not from, I guess one or two first years are there, ma'am, from JJ.
Okay.
Uh, Dr. Mukesh is there from first year. Dr. Mukesh is first year from JJ hospital, from our hospital. Rest are second year, few second years, and rest are third years, ma'am.
Okay. Anyway, I'm not able to send a message. So thank you all, and it was really nice taking a class on skin surgery after a long time. And yeah,
Thank you so much, ma'am. It was a very great lecture.
thank you very much. Thank you very much,
Thank
Dr.
you for
Durga,
teaching
for
with us.
coordinating.
Yes, ma'am. Yes,
Yeah,
ma'am.
thank you.
Thank you, ma'am.
Yeah, bye bye.
Bye.